very low recurrences, but we want to have information on patient satisfaction, on economics, and so on and so on. So this is a accrual of the Aksana study. I'm very happy and very, very thankful for the very strong Turkish team. And you can see we have 400 patients from 14 sites with a very high recruitment rate per site. You know, in Germany we have 160 sites, we have more patients certainly, but there's very, very active sites, and you can see that Turkey is very, very high and much higher than most other countries in Europe, and thank you very much, because this is a real great work. Now, what to do in CN1, Y, CN0, patients who were considered clinical, but then have a positive note. I think the standard of care is X-ray resection of these patients, because we do not have data yet on the effect of radiotherapy. You know, for upfront surgery, we would go for radiotherapy or omission. But the AMROS trial, which showed equivalence between surgery and radiotherapy, is not valid after the adjuvant setting. So the Alliance trial will provide these data. Now, a very interesting group, PN1, Y, CN1. And I think everybody would agree to go for full active lymph node dissection. Quite clear. However, this is a result of the Aksana interim result. 30% of these patients are histologically node negative, because the lymph node appears suspicious, but it's a fibrosis. And I think we have 30%, and this reflects my experience. So I think we have to find some ways to identify these patients, to spare patients with a negative lymph node from full X-ray lymph node dissection. And I think the TAXIS trial is an excellent trial that, I showed it before, really analyzes patients and only resects the biopsy-proven or suspicious nodes, and then performs radiation. Now, an important issue also, what about micrometastasis after primary systemic treatment? And this is a very interesting paper from Stephanie Wong, showing the prognostic impact. And what you can see here is these are patients with a YPN status. These are patients with 3 or more lymph nodes after neoadjuvant chemotherapy, and these are 1 to 3 lymph nodes. Micrometastasis, isolated tumor cells. And you know, and you can see that the prognosis, the prognostic impact of macromets and micromets is quite similar in this study. And this is in contrast to patients who undergone upfront surgery, where micrometastasis have very little prognostic impact. So micromets after neoadjuvant chemotherapy are different. And here we can see the rate of non-central lymph node involvement or non-target lymph node involvement in patients after neoadjuvant chemotherapy. We know that in the upfront surgical setting, we have 18% non-central lymph node metastasis in patients with a positive central lymph node. But in the after neoadjuvant chemotherapy, the rates are much higher, and we have 64% of non-central lymph node metastasis in patients with a micromet. Many people think that we can neglect micromets after neoadjuvant chemotherapy, but they have a different role. So it's quite different. And here we can see patients with a positive additional nodes who have a positive central lymph node after neoadjuvant chemotherapy. 64% for micromets and macromets, the same. Whereas in AMROS and Z11, 27 and 32%. So there's a much higher rate of non-central lymph node involvement after chemotherapy in patients with micromets. So conclusion for I+ and micromets, in contrast to low volume involvement in the upfront setting, low volume metastasis after primary systemic treatment should be considered as N1 and should be treated, I would say. Probably at the moment we go for X-ray resections, future maybe radiotherapy. Now the next question is, can X-ray surgery be omitted at all after primary systemic treatment? And we have seen this again data from the keynote that the very patients with triple negatives who present initially with negative lymph nodes have almost 95% probability not to have any lymph node involvement. And if these patients then have a complete response at the breast, the rate of X-ray involvement drops to 0 to 1.6%. So very, very low. And do we really have to go for X-ray staging these patients? And this is the rationale for the breast 1 study. where in a prospective cohort, patients with a complete response to the breast are enter the study. They must be triple negative, they must be HER2 positive, and then they do not undergo any axillary surgery at all. So in conclusion, surgery to the axilla becomes increasingly a diagnostic tool. Sentinel node biopsy is the standard of care for CN0. For CN1, why CN0 marking the biopsy-proven lymph nodes with or without sentinel lymph node biopsy improves feasibility and accuracy. Some open issues remain, certainly, that hopefully will be solved in the Axana study. Axillary recurrence rate is low independently of the technique you use. And axillary section is, and I would say still in brackets, indicated in YPN1. In macros and micromets, we await the Alliance trial to change this. And axillary lymph node dissection is losing ground not only as a diagnostic, but also as a therapeutic procedure. Thank you very much.
Torsten, would you like to leave directly, or should we take the questions right now, or
I think it
would be better for you? Okay, we can take a few questions, but I would like thank you very much for your excellent presentation. I would like also to make some comments. We have also a big trial, a prospective trial, neocentric trial in Turkey from about 40 centers with an accrual of 2,400 patients, and we presented our first results in San Antonio, in the last San Antonio breast cancer meeting, and we also found that there is a very low rate of axillary and locoregional recurrence, regardless of the pathology in the final pathology, YPN0 or YPN positive disease. The only factors associated with locoregional recurrence were non-luminal pathology, being younger than 45, and residual disease in the breast. So these are our initial results. Of course, we need more data on this setting. And in our center at the Istanbul University, we don't do axillary dissection in every patient with a residual disease in the axilla. We always discuss all the patients with a positive pathology in the axilla following neoadjuvant chemotherapy, and in selected patients, especially with low volume disease in the axilla, micromets or isolated tumor cells, with a complete response in the breast and with a complete radiological response, we can omit axillary dissection. There was a question from Dr. Mahmut Müslümanoğlu actually to you. Maybe would you like to make some comments about doing sentinel lymph node biopsy alone versus targeted axillary dissection?
Actually, I can expand in one case presentation. 45 years old lady, triple negative, get a chemotherapy, and 2-3 positive nodes seems to be in before chemotherapy, and responded very well. You don't know the axilla very well. Could be N0 or low disease. You did a biopsy, sentinel node biopsy, 2 of 3 lymph nodes positive. So what would you advise this patient? You said still standard. I can't believe that. This is a traditional approach, not a standard. We don't have a data on that.
Did I understand correctly? She had, after chemotherapy, 2 to 3 positive lymph nodes in it. After chemo. Now it's clear. Well, I think we have clearly to, we really have to say very clearly that currently the axillary section is the standard of care of these patients. I think we agree about that. This is.
I'm not agree. We select the patients who needs axillary dissection or left to radiation therapy. Our data is not mandatory to do that.
I agree, and I think it's a good way, but my problem is we don't have data. So, and I want to have data, and the data from the Alliance trial is the trial that really proves it. I'm fully convinced that also in the neoadjuvant setting, radiotherapy will be equivalent to surgery, and I think that any actually surgery is mainly staging procedure. But I think we have to follow evidence, and so far Amoros cannot translate it, as I said, in the neoadjuvant because we don't know if chemo-resistant cells have the same respond similarly to radiation therapy than chemo non-resistant cells. And therefore, I think probably you are right, and I would rather go for the.
Mostly
I think
I'm
we
right.
will.
I know I'm right.